So this week, this lecture, we're talking about the meds that are in the New York City REMAC protocols. I left some of the older meds in because in the event that they don't actually switch to the unified protocols in July, we'll find out what happens. So, but you'll have the knowledge. And some of the medications are things that you see patients take on a regular basis, like one or two, that we also happen to, certain areas might actually also carry them. For example, metoprolol is used in Nassau and Suffolk for hypertensive crisis. The city doesn't carry it, but you also have a lot of patients who take beta blockers on a regular basis. So it's kind of one of those things where you really should know it. And if you are going to be working in other regions, that you might actually really, that knowledge is going to benefit you. So without further ado, yes. Hi, good morning. Okay. All right. You're welcome. Everybody put your faces on. All right, so meds. Right up there. So we're going to start with the cardiac medications. These are the ones that you're probably going to use about 60% of the time, okay? As ALS providers, we do tend to deal with a lot of cardiac calls, obviously, because we carry the big old life pack, the do things box, as I like to call it. So it's important as we start to move through this that you understand what the cardiac medications do, as well as how to read an EKG, which we're going to get to in a little bit. So the first medication that we are gonna talk about is adenosine. I'm sure that a number of you have already maybe seen this in action. It's really kind of an interesting medication because it's got its own class of its own classification for as an antidysrhythmia or dysrhythmic. So basically, what it does is it will halt supraventricular tachycardias, right? So your really fast tachycardias, anything that's coming in and over 150 beats a minute, can be used here can be treated with adenosine. However, there's some more kind of clarifications in how it's used. It needs to be used with a narrow complex SVT, and obviously we're going to talk about that more when we get to cardiology, how to determine the difference. But if you look over here, I don't know if this, no, it's not going to work. I was hoping that video would work. I'll show you guys a video a little later about when you actually give adenosine, what it does. So what it does is it slows the conduction through the AV node, right? Because when the top of the heart starts sending so many signals, the AV node gets kind of overwhelmed and it just lets everything go through. So if it's an older individual, they can't sustain that, right? The younger you are, the especially like little babies, right? They can handle a very high, fast heart rate for a longer period of time. Adenosine helps for the older group because if you don't have enough time for the ventricles to fill, the patient's going to become hypotensive very quickly. So when you give adenosine, one of the biggest things that you need to do is talk to your patient, right? So you need to make sure that you explain to them what's going to happen because it's a weird feeling, right? So all of a sudden the patient's heart is just going to stop for a little bit. They're going to have like either a weird crushing sensation or just a strange, bizarre, like anti-flutter. That's one of the ways I've heard it kind of explained. Like all of a sudden there's like a butterfly going on in the chest and then it just kind of stops. So support is really important when you're using adenosine. Traditionally, we give 3 doses, 6 milligrams, 12 milligrams, and 12 milligrams. It is a very, very short half-life, so you need to flush it through the IV very rapidly in order to make sure that the patient gets the medication before it breaks down. So sometimes this can be a 2-person job if you don't have a IV bag set up. Sometimes you'll learn little tricks on how to make it more effective, but this is going to be one of those times when you're taking advantage of having more than one port on the IV line. So you can give the adenosine on a low port and then flush it up higher with a flush on a higher port. Amiodarone. I like to call amiodarone kind of the duct tape of antidysrhythmics. It has potassium channel blocking uses as well as calcium channel blocking uses, but it's primarily considered to be a potassium channel blocker. So what it does is it sort of kind of chills the heart out a little bit. So when the heart is expecting, when you start having like large tachycardias, the heart is kind of just depolarizing and repolarizing very rapidly. When you extend the repolarization section, and again, we'll talk about this more when we're in cardiology, when you start to extend repolarization, the heart can't depolarize again, which means it can't send a new electrical signal. Okay, it gets like a longer pause. So when amiodarone comes in, it gives you and starts to slow down these really fast tachycardias. We use it in VFib and VTach particularly because of that. It kind of helps reorganize the rhythms. But you don't want to give this to patients who are in cardiogenic shock, because obviously that kind of counteracts what you're trying to do. This is somebody who's got a really fast heart rate, nothing slow, nothing hypotensive. Amiodarone is a super potent medication, right? It can live in the body for about 6 months. So if you have patients who have liver or kidney failure, this medication might be not the best choice for them because they're not going to be able to clear it from their system well. Also, patients who are on Coumadin, again, it could have some adverse reactions with that medication in particular. So this is why you have to get a good patient history before you start administering medications. So back on adenosine, we talked about the narrow complex SVT. Here we have a wide complex tachycardia, okay? And again, we're going to talk about that more when we get to cardiology specifically, but the width of the big squiggly, right? Right? This right here, that squiggly, we call that the QRS complex. If it's nice and narrow and tight like that, you're going to be using adenosine. If it's really wide, broad, and kind of bizarre looking, then you're going to kind of fall over to the amiodarone section a little bit more to control tachycardia. Aspirin. Aspirin is very widely used to reduce platelet aggregation. So what happens is when you take aspirin, it comes into the body and it irreversibly binds to part of the platelet and then prevents it from creating thromboxane A2, which you're probably never going to need to know that name again, but just know that when it binds to the platelet, it pretty much binds to the area that helps the platelet get sticky and stick to other parts of the platelet, or other platelets, right? So as the blood is going through your bloodstream, platelets are bouncing and they're just kind of hanging out, and all of a sudden, if like the thrombox, there's an injury and the body starts to make the thromboxane, those platelets start to get sticky and they start to stick together in the area where you need to clot. This helps prevent it. This we use primarily in the treatment for chest pain because the idea is that aspirin will prevent any forming clot from getting bigger. Okay? It does not dissolve a clot. It just prevents it from getting larger. Aspirin can live in the body for about about a week, right? Because that's about how long a platelet lasts. So once the platelet is affected by by aspirin, it's never going to be quite as sticky again. So you'd have to make all new platelets to have the, normal clotting reactions again. Relative contraindication is like an active peptic ulcer, or something like that, because you're going to promote potential like significant GI bleed. But in the grand scheme of life over limb, if you have a patient who's having active chest pain, you're going to still give them the aspirin, okay, even if they have like a GI bleed. But again, going back to Brianna brought up, you have to do a really good patient assessment, right? So if you, for those of you who didn't see the chat a few days ago, did a job once at a urgent care. An older woman came in. She was complaining of epigastric pain. Said that she'd been vomiting up coffee grounds for about 2 days, and now she's having this pain. And what did they do? They gave her 364 milligrams of baby aspirin. Because she had epigastric pain, they couldn't rule, and they did an EKG too, but they couldn't rule out cardiac. And I'm standing there trying not to make the rude face, but I'm going, well, that was just foolish, right? You literally just gave somebody who was probably actively bleeding, and you did a very poor patient assessment on aspirin. You're just going to make her worse. So again, you have to do a really good patient assessment in order to make sure that when you're giving medications that they're appropriate. How do we end up in calcium? Hold up. All right. Atropine. Atropine does the opposite of adenosine. So I know though those two medications kind of sound similar, and I know when I was in medic school, it took me a little while to kind of figure out the difference between the two to make sure I was using them appropriately. But you need to, look at your protocols and see, adenosine slows things down and atropine speeds things up. They're complete polar opposites. So basically what happens is when you give a patient atropine, it blocks the parasympathetic nervous system and its effects on the heart. So if you think of the central nervous system as your sympathetic nervous system is your fight or flight, right? It wants to go, 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 go. Your parasympathetic is your feed and breed, okay? It's chill. It wants to hang out and Netflix and eat some potato chips, okay? It doesn't want to go fast. It wants to just kind of relax. Your heart rate is generally controlled by your parasympathetic nervous system. If your sympathetic nervous system had complete control over your heart rate would be like in the 200s all the time, right? It's just going to be amped up. It's going to be really high. The parasympathetic kind of comes and puts the brakes on it, okay? Sometimes the parasympathetic nervous system can get a little too enthusiastic and cause bradycardias, okay? There's a number of other things that can cause significant bradycardias or symptomatic bradycardias. That's what I was looking for. But when we use atropine, we're trying to release the brakes, right? We want to give the sympathetic nervous system the ability to raise the heart rate by antagonizing the parasympathetic nervous system. We use this in primarily just the sympathetic bradycardia protocol. However, this is also part of the duodote antidote. So if you have a weapons of mass destruction job, right, and you have patients who have organophosphate poisoning, this is what we use, okay? We use atropine in combination with 2-PAM to kind of counteract the organophosphate, which again, interferes with the parasympathetic nervous system. If you administer atropine too slowly, you can cause the heart rate to go down even further. So you have to just make sure that you know the rates at which you're supposed to administer these medications. So atropine and adenosine are both IV push medications, right? They need to be given quickly in order to not have counteraction or interactions of the opposite direction. Calcium. We talked a little bit about calcium. It's obviously elemental electrolytes. We primarily do not give calcium chloride for anything other than suspected electrolyte imbalances in cardiac arrest. It is in the protocols for bradycardia as a a medical control option. That's the word I was looking for. But good luck. In my experience, medical control is very wary of giving people orders for calcium chloride. They just go to the hospital because they want, I guess, more significant cardiac monitoring than what we can do, which is not really that much different, honestly. So when you increase the amount of calcium in the body, the idea is that it will make the cardiac muscles able to contract more effectively, okay, stronger. So in the presence of cardiac arrest or cardiogenic shock or something like that, calcium can be potentially useful, but it also depends on what else is going on in the body. If you are administering calcium chloride during cardiac arrest, you need to make sure that if you are doing it in conjunction with sodium bicarbonate, that you flush the line out very thoroughly. I recommend giving the calcium chloride first, just because it's a smaller ampule than sodium bicarbonate, so it's going to be a little easier to flush the line effectively. But if you mix the two together, you literally will create chalk within the IV line. Doesn't look good going into the hospital with that. Cardizem or diltiazem. This is our magic drug that we use mostly for AFib and aflutter. This right here says RVR is rapid ventricular response. So when you're giving this to a patient, it's the opposite of calcium. So it blocks calcium influx into the heart so that it doesn't have the ability to contract as enthusiastically, right? It kind of slows everything down. It says, all right, guys, you can chill. This is kind of important because it's sort of slowing down the ventricular response when you have a rapid AFib, aflutter. So it's increasing that time that the electrical impulse is sitting in the AV node, okay? This is one of those things where they're cautious. You have to call and get permission to give this because it can create significant hypotension in patients. And also, again, liver and kidney dysfunction, patients can have a lot of issues with it because it's such a potent drug. Sometimes patients also who have Wolff-Parkinson-White syndrome down here in the bottom right corner, or WPW, they may not have good responses to cardizem. Again, we're going to talk about it more in cardiology, but WPW has an accessory pathway from the atrias into the ventricles. So it bypasses the AV node altogether. So if you kind of slow the AV node and you're just now letting everything kind of pass through this accessory electrical pathway, you could have a patient who has increased heart rate rather than decreased heart rate, which you were hoping for. And we'll teach you how to determine that on a EKG as well. Now, whereas we had to push atropine and adenosine very rapidly in order to get the required response, cardizem you need to deliver very slowly, okay? And when you guys come back into the labs and you do IV skills and stuff like that, you'll kind of see what, you're going to, give the patient the medication. You're going to give them maybe a milliliter, flush it through, give them another milliliter, flush it through, right? Because now you're going to make sure you're monitoring them closely so they don't have a significant drop in blood pressure, and then you're rushing to fix that because of the adverse reaction to the medication. Dopamine. I know you guys were really excited about it. And here's your answer for the differences between dopamine and norepinephrine that we were talking about a little bit before, right here in the corner. So dopamine increases how well the heart contracts and the amount of blood that the heart can pump out due to the increased contractility. It's used in shock states, so anyone who might be dealing with a number of different It could be cardiogenic shock, septic shock, etc. I've used it before in patients who have had beta blocker overdoses. It can be used in a number of different ways in order to, manage that. So this is why it's very, very important that you make sure that you calculate your dopamine correctly. So between 1 and 5 micrograms per kilo per minute, it's usually just affecting the kidneys, okay? It's kind of just working in that area, but we're using this for stroke situations, so we want to have 5 to 15 mics per kilo per minute. Yeah, I know there's a little overlap, but, at 5 mics, which is usually kind of where we end up giving patients dopamine, it has a little effect on the kidneys and a little bit an effect on the heart as well. So you're increasing your contractility as well as increasing the blood flow back into the systemic circulation away from the kidneys. So you're kind of improving overall. That's why we live here in this kind of gray zone. And then if you give the patient a super lot of dopamine, where you're 20 to 50 mics per kg, this is when you go to the hospital and you maybe didn't label your dopamine bag as clearly as you thought you did, and the nurses turn it all the way on, and the patient's blood pressure is all of a sudden 300 over 200. That's here. You've constricted all of the blood vessels in the periphery, so now their blood pressure goes whoop, right through the roof. Sometimes patients can have some adverse reactions, headache, anxiety, etc. Dysrhythmias are really the ones you really kind of want to watch out for when you're administering dopamine. If you are giving dopamine, most of the time I've found statistically you're kind of giving it to patients who've had ROSC, so they don't complain too much about the whole headache, anxiety bits. Epinephrine, very popular drug, happens to be in a number of different protocols. The 1 to 10,000 or the IV drip, which is they just added. Well, we don't have that in protocol. We have the push dose epi, which we'll talk about in a little bit, is primarily used in cardiac arrest. A cardiogenic shock is where you're going to see or septic shock is where you see the push dose epi. And we'll talk about that, as I said, a little bit later. Your body naturally makes epinephrine. So it's stimulating, it's agonizing your sympathetic nervous system. So it increases heart rate, it increases the contractility of your heart. If you've ever had somebody scare the bejesus out of you and you feel like your heart is pumping out of your chest, that's epinephrine. Okay? So epinephrine, when you're giving it in cardiac arrest, can bring back like a frozen chicken breast. It's really impressive, okay? So you might end up getting cardiac rhythms on patients who've been down for 2+ hours because, the body's like, okay, cool, we'll try it, but the brain is already dead. If you do have a patient who is on a beta blocker, you might see that it doesn't work as well as you expect. Other side note, epinephrine is highly acidic. So if you think about, and we talked about acid-base a little bit in the last module, if you think about the body during cardiac arrest, it's not blowing off carbon dioxide, which means that it's becoming a highly acidic environment, which means if you continue to raise the body's acidity with epinephrine, you are not going to get that patient back. And this is why high quality ventilations are extremely important during cardiac arrest, because now you as the provider can provide those ventilations and you're restarting internal and external respiration, right? Andrew, we talked about that. It was a great question. Now you're reinitiating respiration, so you're getting that carbon dioxide out of the system and you're kind of repairing that acid-base balance through ventilation. So you want to make sure that you're doing both of these things in conjunction, otherwise you're just creating vinegar, essentially. You're turning the body blood, that body's blood into vinegar. Lasix. Lasix is a loop diuretic, which means that it works in the loop of Henle, which is one of the parts of the kidneys, obviously, and it helps reduce the amount of fluid in the body. All right, so Lasix, which is, if you look at the word Lasix, it lasts 6 hours. when you kind of look at how it functions and it's pulling a lot of the fluid out of the body, these patients might be dehydrated, okay? However, these patients are also very sensitive to fluid overload, right? There's your CHF patients who, if they have, a salty meal, they're going to end up with pulmonary edema, right? If they drink one glass of water too much, they might end up with pulmonary edema. This is another one of those medications that are kind of only used through medical control orders in the APE protocol, which is right here. They're not numbered anymore in the new protocols. A lot of the times it's not even worth it to call and ask for Lasix, because you're putting this patient on CPAP and you're just mechanically taking care of this rather than doing it pharmacologically. Lasix also has its own kind of risks, right? If you are going to give this to a patient who receives dialysis, you're not going to have any real quality results because their kidneys aren't working to begin with. If you administer it too quickly, you can give that patient a permanent tinnitus, right? That ringing in your ears. That's a good way to make some enemies. Also, it is to a certain degree weight-based. If you have an adult who is less than 40 kilos, which is about 88 pounds, right? So those little tiny grandmas, you're going to reduce that dosage to 1 mg per kg per dose, okay? And that's in your GOPs. Primarily in the protocols that we have in the city, we use lidocaine only for topical anesthetics when using an IO in a live patient, if you're feeling really nice. And that's 1 milligram per kilogram to a max of 50 for the first dose and 25 for the second dose, I believe. However, lidocaine, if it goes systemically, is also a sodium channel blocker, okay? So it will decrease how quickly the heart is going to depolarize and repolarize. In the event that you don't have amiodarone on your truck someday, right? You can use lidocaine in exchange for it. Very infrequently used for cardiac dysrhythmias in New York City. I don't think that it's in any of the other counties either. It can cause a lot of other issues in terms of high level heart blocks if you give too much. And again, issues in the liver. MAG is used in a number of different situations. It can be used as an antidysrhythmic. It's only used for Torsades de Poix, which is the multifocal VTAC, which again, we'll talk about that when we get to cardiology a little bit more. It's also used for seizures for for eclamptic patients. So that's where you'll see that pop up again. It's also used in the asthma protocols because it does have the whole idea behind magnesium is that it reduces muscle contractions, okay? It relaxes all those muscles. You have one of those things if you're supplementing with magnesium, you have enough when you are having loose bowel movements because it's relaxed everything so well that it's just moving right through and you're ending up with diarrhea. So that's just a random little idea to help you remember what magnesium does. When you are giving magnesium, it does need to be diluted. If you're giving it in a cardiac arrest or in a Torsades de Poix situation, it's going to be at 10 milliliters of normal saline. If you are giving it to a patient who is having seizures from eclampsia, it's going to be in 100 milliliters normal saline. I've had one patient ever who was awake and in torsades, and she was sitting there going, I'm having a little chest discomfort. So I was like, all right, we'll do a 3-lead, we'll do a 12-lead. And I go to tell her, you need to sit really still because, there was movement on the monitor. And she's sitting perfectly statue still. And I look back at the monitor and it was in torsades. And I go to my partner, I was like, Bruno, look. And he's like, well, oh, shit. that's Torsades. I was like, yes, you want to call for mag? So we ended up getting mag, but it stopped on its own. So they told us not to give it until we saw it again, which I think was kind of silly. But again, medical control, they're the ones with the doctor degrees and the high level of bills. All right, so nitro. I think we're all pretty familiar with nitroglycerin. We place it underneath the tongue. Patients go, oh my God, this tastes disgusting. And it usually is supposed to help with their chest pain. If a patient has their own nitro and they've taken a number of them and has had no improvement to chest pain, their nitro is probably kind of aged out. Okay, it's probably expired. Nitro is another medication that has a very short half-life, okay? So it gets in, it works really fast, but about 2 to 3 minutes later, it's gone, which is why in your acute pulmonary edema protocol, you're giving it every 5 minutes with no upper limit, okay? Nitrating patients in acute pulmonary edema is a very effective treatment. It's unfortunately very difficult to nitrate a patient who has a CPAP mask on their face because you have to stick it under their tongue. So, elderly patients might have a more significant blood pressure change because they don't have as good of compensatory mechanisms when it comes from, the elasticity of vasculature. So when it dilates everything, they're going to go from one extreme to the other. Patients who have taken erectile dysfunction medications within the last 72 hours are usually contraindicated. However, you can call medical control and get permission to give them the nitro anyway, especially if their blood pressure is elevated. I had a patient once who had a blood pressure of like 180 over 100, was having active chest pain after having had sex and with, erectile dysfunction medication. And we got approved to give him nitro, and he was actively having an MI. So it's one of those things where you need to, again, look at the entire clinical picture of the patient before you make a decision if you're going to say, no, it's okay, or ask permission to give something, even though it's contraindicated. So norepinephrine, another name for norepi is Levophed, and then the terrible, dark, gallows humor medication name for it is Leave 'em Dead. Norepinephrine has a very short half-life. So if you have a patient who is on norepinephrine and they're relying on that for blood pressure support and you turn it off, their blood pressure is going to tank within seconds, okay? This is why transport medics need to make sure that if you're transporting a patient on norepi and if it looks like the bag's a little low and you have a 2-3 hour trip, that you make sure you get another bag of norepi to bring with you. So norepinephrine works in the alpha 1 side of the sympathetic nervous system, increases the contractility of the heart, and it also constricts all of the peripheral vasculature. So the heart starts to pump a little more effectively, and you're shunting blood back to the core. There's a bunch of research that shows that it's most effective for septic shock patients, much more effective than dopamine. So it's kind of impressive how effectively it works. If a patient does have something like hypovolemia, though, you're not going to give them a vasopressor, okay? And this is, again, goes back to making sure that you've done a really good patient assessment. If they have a patient who is extremely shocky, but it's due to the fact that they have like a GI bleed and have been, bleeding from the anus for 3 days, you don't want to give them a vasopressor, right? Those are the patients who need fluids more than anything else. Always make sure that if you have to give a patient a vasopressor, that you're giving it in a large vein, in one that you have checked to make sure that it's really good, because if it does infiltrate and you're putting norepinephrine into the surrounding tissues, it will constrict all of that and cause necrosis, as will dopamine. Okay. It's also preferred that norepinephrine and dopamine are administered through an 18 gauge needle at the very least, because they want to be able to make sure that flow is good, and it's in you're going to put a 18 gauge in a larger vein than you're going to put a 22 gauge. So we talked about sodium bicarb a little bit when we were talking about acid-base again. This is your metabolic buffer, so it helps in acidic situations such as cardiac arrest. is also can be used for patients who are potentially in DKA. Okay, it's going to help bring their acid back to their acid-base balance back to a normal range. Patients who have overdosed on aspirin, right? That's another acidic medication. Bicarb can help. Tricyclic antidepressants. This helps prevent them from going into VFib arrest. Again, this is one of those things you want to make sure that you have a good vein. You also want to make sure that you flush the line appropriately if you're giving it in conjunction with calcium. Oxygen. Oxygen is kind of our go-to, right? Oh, you don't feel good? Here's some oxygen. Oh, you have shortness of breath? Here's some oxygen. It is used to reverse hypoxemia, right? So you want to help improve patients' SpO2 levels, and you want to just make them more comfortable. Patients who are experiencing ischemic chest pain, I know that the protocols say to put them on a non-rebreather at 15 liters per minute. However, that extremely high flow rate of oxygen has also been shown to cause lethal dysrhythmias upon reperfusion. So you go through all the trouble of giving that patient aspirin and giving them nitro and giving them oxygen and getting, calling in your STEMI note and getting them safely to the hospital so that they can go get them upstairs, right? They're going to do an EKG. They're going to bring them up to the cardiac cath lab, and they're going to they're going to reperfuse that heart with some stents, and then that highly oxygenated blood is going to cause them to have a dysrhythmia and then die. Okay? So be judicious in how you administer oxygen, especially in STEMI patients, because you don't want to end up ultimately causing more harm than good. However, if your patient is extremely short of breath, do not withhold oxygen, okay? You want to treat the patient to an appropriate level where they're comfortable. So if you have to put a cardiac patient or a COPD patient on 4 liters of oxygen via nasal cannula, and that helps them with any shortness of breath, then that's, more than adequate, right? That's appropriate care. If you have a patient who's having significant chest pain and they're having a hard time breathing and they aren't getting better on, a nasal cannula, then give them a non-rebreather, okay? You have to start to think a little more clinically and critically when you're looking at your patients. And I'm sure some of you already do it now, but that's also kind of tying into how you're going to document, right? So you're not going to say like, we withheld oxygen. All right, you have to be cautious in how you do that too. All right, any questions before we move on to respiratory medications? I saw the chat blow up a little bit. Anybody? Anyone want to tell me what's going on in the chat if you have questions there? Because I'm having a hard time getting to it. Yeah, that's a really in-depth question, actually. So technically the quote-unquote idea of quote-unquote blood thinners is kind of like one of those like lay people terms. So the original blood thinner was Coumadin because it literally affects the INR and how quickly a patient is able to clot. But it doesn't actually change the viscosity of the blood, if that makes sense. So like the blood is always, a certain viscosity, and there's like not a medication that's going to make it like quote unquote thinner. It's just going to make it so that it's doesn't clot as quickly. I'm probably not explaining this the best, but basically there's like the platelet preventions, and then there's the other side of them, which I'm totally blanking on the names of it right now. So yes, technically if you look at what aspirin's function is, it is technically a blood thinner. If you bring it into a trauma center and say patients on aspirin, they're going to say no, aspirin doesn't count as a blood thinner. But I've seen plenty of elderly people who are only on aspirin have pretty significant brain bleeds from only being on aspirin. So I think the medical community is also kind of in debate as to whether or not it's a blood thinner. Which I'm sure that didn't answer your question really at all, but that's the best I got for you. Mm-hmm. Mm-hmm. It, it could. So basically, aspirin can be one of the triggers that cause like asthma attacks. So that's why it's a relative contraindication. Because again, if you're having a heart attack, we can fix your asthma attack, but we can't, we need to give you the aspirin to prevent the heart attack from getting worse, kind of thing. Okay. It's a combination of different things. So your vasopressors have a significant alpha interaction. Epi is a beta agonist as well as an alpha agonist, right? So it affects both sides. So just like if you're having a patient who has a bad asthma attack, you can give them an EpiPen because it's going to dilate everything in the vasculature, just like asthma or anaphylaxis. Epi works for it as well, because you're dilating the blood vessels, you're constricting some of the blood vessels in the alpha side, but you're dilating the bronchioles. So yes and no, it depends on what you're kind of doing, I guess. But the vasopressors, yes, they do primarily work on alpha. Any other questions? Okie dokie. Moving on. Your respiratory meds. Albuterol. Conveniently right here. So, albuterol is a beta 2 agonist. Okay, so we just said a little while ago. When patients are having an asthma attack, it constricts the muscles in the bronchial tree. So albuterol comes and prevents that constriction from happening so that it's easier to breathe. Albuterol can, depending on the age of the patient, create chest pain and dysrhythmias, especially if the patient has already taken a significant amount of albuterol on their own to try to fix their asthma attack. Patients who are on beta blockers, you might not see as a strong effect of the albuterol because, again, if it's a non-specific beta blocker, you have to overcome the beta blocker's effects on the lungs before you can actually start dilating things. Patients who take significant amounts of albuterol, right, so they've been having, say, for example, like a hard time breathing all day, they took their inhaler, and they're kind of not getting any better, but they keep trying with their metered dose inhaler, they can get really nervous and kind of twitchy. Because again, it's affecting the sympathetic nervous system. It's that fight or flight response. So they're getting that very kind of jittery response that you also can see with epinephrine administration. It's also very useful in anaphylaxis for the same reasons. It's useful in asthma. It helps the breathing improve. Dexamethasone. I know that this has become the primary preferred steroid in our protocols out here. I'm sure it's moving into the city as well. It's supposedly a little more potent than Solumedrol, which is the other one, but not as much fun to mix. So dexamethasone, your standard dosage for dex is 12 milligrams. It can be administered IV or IM, and it helps reduce inflammation, right? So as the body responds to asthma, it starts to cause an influx of mucus, right? Because it's the body's response. It's to the entire asthma cascade. It's, you have the muscle constriction and then you have a mucus influx. So what steroids do is that they kind of stabilize the cell walls that are within like the entire body. And by stabilizing the cell walls, it prevents that mucus influx, right? Because that mucus is coming from the fluid inside the cells. So if you can't get access to that fluid, you can't have a mucus influx. It also works similarly with anaphylaxis, except in a slightly different way. It stabilizes the cell walls, but the cell walls that it's stabilizing are not only the mucus production cells, but it's also the ones that are releasing histamine, which is creating the anaphylactic reaction. Steroids are very sensitive to heat, so sometimes the back of a hot 90-degree ambulance is not necessarily the best place, so you might not be as potent as you'd expect. It has been used in kind of mixed, again, like patients who are septic, they have a mixed response to steroids. Like in the hospital, they'll potentially give them some steroids to kind of help boost their cell stability, but at the same time, it also can suppress the immune response, so it might not be helpful in terms of fighting an infection, but it's good in keeping the infection from spreading. So it's kind of a mixed bag of success there. One fun side effect that steroids do have is they can cause psychoses, and you see this a lot in patients in the hospital, like less than or more than we see them in patients in our ambulance. You'll give them the dexamethasone, they'll start like taking off their clothes or having a little psychotic break, and it's primarily just due to the steroid, which is kind of one of those quirky little side effects that you don't really see that often. Diphenhydramine, or Benadryl. A number of cells in your body have what is called the histamine receptors, right? This is what creates your allergic reaction. Even in like the pollen situation right now, right? Your body identifies an allergic or an allergen, and then your body has a histamine response where it's like confetti. The cells explode and like release histamine into the body, and that's what creates your sneezing and stuff like that, because it's your body's kind of attempt to protect itself. However, you have patients who have allergic reactions, that response gets a little overenthusiastic, and they start having, difficulty breathing, etc., etc. So what Benadryl does is it comes in and it blocks the receptors for histamine on the H1 receptor, so that the cascade, the allergic cascade can't continue. Okay, so it reduces the severity of it. It also can make people drowsy, which is one of the reasons we don't give it to infants. They commonly will give it for also for reduced vomiting, because sometimes if patients take an allergen in through the oral route, they will be vomiting enthusiastically because the body's trying to get rid of the allergen. It's also great for dystonic reactions. So if you have a patient who is on long-term antipsychotic medication and they're having that kind of characteristic spasming of the muscles, Benadryl does a wild job in removing or reducing the dystonic reaction. So we had Epi 1 to 10,000, and now we have our Epi 1 to 1,000. So this is your more potent, more concentrated IM epinephrine, okay? Comes in either a small vial or a little ampule, and it does exactly the same thing as Epi 1 to 10,000 does, but it doesn't create as much acidity in the body, and it's usually used to treat anaphylaxis and severe asthma, okay? You can take this epinephrine and you can also put it in some normal saline in a nebulizer and use it for croup as a medical control order, okay? Again, same problem with beta blockers that the regular old epinephrine had. Patients often will have a kind of jittery response to the epi, but not right away. It takes maybe about 10 to 20 minutes before you fix their breathing or you fix their anaphylaxis, and now they're kind of just shaking. They're I can't stop shaking. Okay, it's a totally normal side effect. It's just extremely uncomfortable for some patients. Ipratropium bromide. So this is one of those medications that we give in combination with albuterol. We use it to treat asthma and COPD. And we combine the two, but only 3 doses of ipratropium bromide. So where albuterol works on the sympathetic nervous system side, ipratropium and albuterol agonizes it. Ipratropium antagonizes the parasympathetic nervous system. Okay, so you're now kind of doing a dual attack from both sides in order to help reduce the symptoms of asthma or COPD. Right. So if you're dilating everything on the sympathetic side and you're preventing constriction on the parasympathetic side. Hope that makes sense. It's also, with its parasympathetic effects, it also helps to dry out the secretions by blocking acetylcholine. So you know the mad as a hatter, dry as a bone. I'm blanking on the other ones. We're working on the dry as a bone part, right? Because it's going to block acetylcholine and help dry up all the secretions. It's the opposite of sludgeum. Okay, that's the effects that it's creating. It was originally, when they made ipratropium bromide, it had soy byproducts in it, so patients who were allergic to soy were having like an allergic reaction to ipratropium. I don't believe that the ipratropium that we carry has much soy in it anymore, so I think that might no longer be a significant contraindication, but it's also very important to make sure that you do ask patients about their allergies. So we talked about MAG previously. This is, again, same thing, same concept. It's going to reduce muscle constriction. We're going to use it for seizures of eclampsia, and we're going to use it as well for asthma in order to relax the bronchial tree. Methylprednisolone, or solumedrol, probably the most fun medication to give, just because you get to pop the little rubber stopper and mix it up. Again, it's a steroid, does pretty much the same exact thing that dexamethasone does. It can be used also in acute spinal trauma, not that we use it for that, but, you know, if you're feeling wild and crazy and want to call in a medical control option, it's a possibility for you. Racemic epinephrine, we do not specifically carry this, but as I just said with the Epi 1 to 1000, you can make your own racemic epinephrine. It works pretty much the same way that albuterol does, but a little more effectively for children with croup, because it also reduces the swelling in the airway that the croup infection causes through its alpha agonist properties. Okay, again, same difference, same thing. You get a little twitchy, get a little nervous, but it can be very effective for patients with croup or super severe asthma. So terbutaline, I've never seen it on an ambulance. New York State loves to ask about this medication because it can be provided in an oral tablet, or it can be nebulized and inhaled. It is a beta-2 agonist, so it relaxes the bronchial tree, doesn't have as many effects on the heart rate as albuterol does, so that you won't get that like serious tachycardia. But I don't know, I've never seen it. I just know the state likes to ask questions about it on a regular. Questions on respiratory. We all still here? It is for the endocrine medications. Willard something or another. Diabetes. All right. Powering through. I like your tenacity. So dextrose, D50 or D10 or D25, okay? Nassau and Suffolk no longer use D50. because when you administer D50, you're creating a serious sugar spike for these patients, where you don't necessarily need to, right? You can give a patient an IV drip of D10, wake them up gently, and then let them eat something and not really screw up their entire sugar life, okay? D50 also is extremely like kind of fast acting, right? So you'll wake up, they'll be awake, no problem, right? And then like, depending on how much insulin's in their system, that's going to do a really good job of putting that sugar back in the cells, and their blood sugar is going to drop. Okay, so you're giving them these really high peaks and these really low valleys, which is why they've moved from D50, like shooting them a big old amp of D50, to a more gentle D10 infusion. Also, if you have a patient whose IV has infiltrated and you're giving them D50, you can cause a significant amount of tissue necrosis in that area. So D10 is a little safer because it's not as acidic and it doesn't cause as much necrosis, and you can probably catch the infiltration before significant damage is caused. We use dextrose in a number of different protocols. It's in the cardiac arrest protocol as part of the H's and T's, right? So the H's and T's, and we'll talk about this a little bit more when we go into critical care of the patient. Your H's and T's are a list of different things that can cause cardiac arrest. Hypoglycemia being one of the H's, right? So if a patient's sugar gets so low that their brain can't function, their heart can't function, they will die. So you can give D50 if you check a patient's blood sugar and it's low in a cardiac arrest, and you might have, some improvement. Seizures are similar, right? So if a patient's blood sugar gets really low, they can end up having a really bad seizure. I think the lowest blood sugar I've ever had was 12, without it just saying low. The lowest one I've ever had was 12. And she was really out of it, right? She wasn't seizing and she wasn't dead yet, so we managed to get to her in time. Not that her family was trying to help, but so going back to kind of the necrosis area of things, so if you have a patient who you suspect is having a brain bleed and their sugar is on the lower side, you want to really be careful with dextrose, because just like how the dextrose can cause tissue necrosis in the immediate area of where you're administering it, increasing the dextrose in the blood as a whole can also cause necrosis and death to the area of the brain that is bleeding. It's bleeding into. Okay, so you really want to make sure, again, this goes back to making sure that you have done a good and proper patient assessment and patient history to kind of find out what's going on before you start giving medications. Glucagon. Glucagon is a medication that we use when we can't get a line on a diabetic patient right away, or if you have a patient who's seizing and their sugar's low and you can't get a line on them. For the most part, glucagon is only effective if the patient has glycogen stores in their liver. Okay, so patients who are alcoholics, you will not see a significant difference if you give them glucagon in their blood sugar. Diabetics, like really chronic diabetics, again, they're not going to have the same glycogen stores that a healthy individual has, so that glucagon might not do as much as you're expecting. Your body normally makes glucagon, so it's a relatively natural hormone, so you're not going to see patients who are like allergic to it, and if they are allergic to it, it's usually the preservative. But again, this is something that you're hoping that you're maybe going to get the patient awake or more awake so that they can eat something, because you can't get an IV for D50. So oral glucose. So all the textbooks label oral glucose as a buccal medication, which is not really true. 1978 is when they discovered that oral glucose must be swallowed in order to actually be effective, that it has little to no absorption through the buccal membranes. It does have minimal absorption through the top part of your tongue. However, not really enough to make your blood sugar go up significantly. So in order to give oral glucose, the patient does need to be awake. They need to be able to swallow, okay? Relatively safe in terms of administration if your patient is awake. I like to try to remind people that if you do have a patient who is a diabetic, who's having a diabetic emergency, but they're awake and able to swallow, you should start with oral glucose, okay? Because for the most part, diabetic patients, they know the drill. If they can get their sugar up and they eat food, they can stay home. They don't have to go to the hospital. And honestly, in the grand scheme of things, it's better for those patients to stay home, because now you're just bringing them to the hospital for them to do what? Check their sugar? They usually can do it at home. For the most part, a lot of diabetic emergencies for patients who know the drill is because they didn't eat soon enough after administering their insulin because they got distracted, or they were exerting themselves more enthusiastically than they usually do. So a lot of that, let's start an IV and give them D50, isn't necessarily in that patient's best interest. So if they are able to eat and swallow, start with glucose, or have the family make them a sandwich, okay? But please check to make sure. We had a patient once who his wife was making him sandwiches, like peanut butter, or just jelly sandwiches because they didn't have peanut butter. And she was using sugar-free jelly because the patient was a diabetic. And I was like, well, we're going to be here all day with the sugar-free jelly because it's not going to increase his sugar. So just make sure that when your patient's being fed, that they're being fed something that actually contains carbohydrates or sugar, because, that keto stuff isn't going to help them. Hydrocortisone was used in the Nassau and Suffolk protocols. They've removed them since. This is Solucortef. Just something good to know, it is used for patients who are having Addisonian crises, which is a failure of the adrenal glands to make enough cortisol. So hydrocortisone can be used to replace it, because what happens is there's a huge fluid shift from when they're not making enough cortisone. There's a fluid shift from intravascular to extravascular spaces. And hydrocortisone kind of puts it back where it needs to be so that you improve their blood pressure. Solu-Medrol can be used in replacement of hydrocortisone in the strange and unusual chance that you actually do have a patient who's having an Addisonian crisis. Just something good to know. You're probably not going to need to really think about that much more. Any other thoughts, questions, concerns? Alright, cool. OB meds. Hey, Mag, here it is again. It's the duct tape of electrolytes. Hangs out with amiodarone. They get drinks on the weekends. This is for preeclampsia, because clearly my preeclampsia and my asthma attack slides got switched. You are going to dilute it in 50 to 100 milliliters of normal saline in order to give it to a patient who is having seizures of eclampsia. It works pretty well, which is pretty wild, because they don't really know why it works in eclampsia. They just give it. We give 2 grams of MAG. In the hospital, they give and that's like a considered a quote unquote high dose in EMS. The hospital gives 8 grams, not milligrams, grams. Okay, so that's a lot of magnesium. So just kind of keep that in mind. And that was all of your OB meds. Pregnant ladies, they have it tough. Going back to, we'll talk about it a little bit in sedatives, okay? So, diazepam. A lot of places do not currently carry diazepam because there was a shortage about 3 years ago, and it was just too difficult to get your hands on it, so they just switched to using just midazolam. Benzodiazepines are very difficult to overdose on. They work really, really well to sedate patients as well as to reduce seizure activity. Patients who are older, you really should be cautious because they can be very, very sensitive to it, right? So you don't want to snow them into the next week, okay? Or as we like to call it, you don't want to midazzle them into next week. So basically what happens is it enhances the effects of GABA, which is a neurotransmitter that causes calming and relaxation in the brain. Diazepam was kind of special because it also had amnesiac effects. So if you were going to sedate a patient to tube them, right, they're awake and they're having a really hard time breathing, and you used etomidate to paralyze them, you would pair it very commonly with diazepam, because then they would forget that you shoved a tube down their throat, and then you guys could still be friends afterwards, okay? Because that's a kind of a traumatic experience that people just don't want to remember. Speaking of etomidate, yeah, go ahead. Yes, they are. It depends. So if it's like a really aggressive drunk who's swinging and, spitting and aggressive, he's gonna take a nap. I'm sorry, he's not getting in my ambulance. But yeah, if you have a drunk who is having really bad like DT tremors or seizures from withdrawing from alcohol, again, you would want to make sure that you keep a really close eye on them, but there's no reason that you're not necessarily going to give it to them you just have to make sure you monitor them, I guess, is probably the best answer. Okay, good question though. So etomidate is really good at paralyzing or like quote unquote paralyzing patients, because it's more of a hypnotic effect. We use it all the time in the city to knock people down so that you can tube them. It's also, in smaller doses, can be used to kind of hypnotize, that's the word I'm looking for, hypnotize a patient so that you can synchronize cardiovert them. Personally, I don't think that etomidate is the best medication for synchronized cardioversion, because it's a very short half-life. It works to about maybe 90 seconds. I know it says it can work up to 5 to 10 minutes, but when you're trying to get a tube in this patient, I'll tell you right now, if you get it for more than 2 minutes, you're lucky. You have to move quickly once you administer it. But if you're going to synchronize cardiovert somebody, you might have to do more than one round. And if it's a short-acting medication, they're going to feel rounds 2 or 3, and they're not going to be like as relaxed as someone who maybe you've given some diazepam or midazolam to, right? Those guys are going to be way more chill. So another thing with etomidate, you have to make sure that you administer it rapidly, because if you do not push it fast, you will actually cause the patient to not be sedated, okay? They'll actually end up, their jaws will clench. They won't go down. Like they'll still be awake, and you're like, well, that didn't work. So this is a rapid push medication. There's also contraindications for using more than one dose. So like if you give a patient etomidate and then they don't go down, and you call back to get a second dose of etomidate, you're kind of shit out of luck. You might want to use a different medication altogether. Patients who have suffered a TBI, like for example, if you're trying to sedate someone who's very aggressive after suffering a head injury, it will help reduce the intracranial pressure. So it has a little bonus positive side effect for some patients. I have seen flumazenol used once. We do not carry it. It is a hospital-only medication, but the New York State exam will always ask you about it. It is the antidote to benzodiazepines. So we don't carry it because benzos are relatively benign, right? You really, really can't overdose on a benzo. You will be sleepy and not really particularly the most talkative patient, but you're not going to overdose. You're not going to necessarily die from it. So if you try to fix a benzo overdose with flumazenil, you end up with essentially a honey badger in the back of your ambulance. So it's aggressive. It's a very aggressive drug. The one time I saw it, the lady went from being like chill, like she overdosed on her benzo. She took like a sleeping pill. She overdosed on that, but she was also a bad COPD patient. So we're trying to fix her breathing. We get to the hospital, and the doc goes, let's give her flumazenil. And she went from being like, no, I'm good. I just need a cigarette and coffee. I'm just a cigarette and some coffee, to trying to take the doctor's head off. So amusing to watch, extremely unpleasant for the patient. If a patient is on long-term benzo treatment for seizures, you can put them right into a seizure by using flumazenil. So this is another reason that we don't use it. So it's just something that you need to know because it usually pops up on the state exam. Keep it in the back of your mind as an antidote. Ketamine. Ketamine was originally designed to be a veterinary tranquilizer. You can knock horses out with it. It's literally a horse tranquilizer. In the UK in the 90s, people were using ketamine or Special K to get really high. Okay, Clockwork Orange, Train Spotting. There's 2 books literally talking about ketamine drug abuse. Or if you want, you can watch them at the movies also. Ketamine is a dissociative medication. So basically what it does is it takes your brain and it puts it into a complete other world, okay? Commonly causes hallucinations when a patient's coming off of a ketamine high, but it's really good for patients who you need to sedate. A lot of places are still don't have like the approval to carry ketamine, or they're working on it. But it will raise blood pressure, which is potentially an issue. But if you want to knock someone out till next Tuesday, or you want to make sure that you're going to be able to effectively tube somebody in combination with etomidate, ketamine's your drug of choice. They use ketamine a lot in the UK EMS system. It's like they're one of their favorite drugs. Lorazepam got taken off of the ambulances, I want to say about 6 years ago now, because while it is a fantastic medication for sedation, especially for seizures and EDPs, it needed to be refrigerated. So we went from carrying it to not having it. So our benzodiazepine field went from we were carrying midazolam, Ativan, which is lorazepam, and diazepam, to now we're just carrying midazolam because we can't refrigerate it and we can't, get diazepam. Works in the same way. It was a slightly smaller dose in the protocols than the other 2. So Ativan, you were kind of giving them about 2 milligrams, where you're giving 10 milligrams of midazolam. You see Ativan given in the hospital a lot because they can just keep giving it, right? It's a patient's aggressive and swinging at nurses. Patient given 2 milligrams of Ativan. Patient still aggressive. Patient given another milligram. Patient still aggressive. Here's another milligram. So 16 milligrams later, they're having a great day. The nurses are no longer getting swung at, and everybody's happy. Midazolam. Oh, go ahead. It's okay. I'm not sure. I will look into that because I don't know. I will let you know. All right. Any other questions? All right. So midazolam is our current medication that we're using to sedate patients. Works really well. It's great IM. They also approved it for IV administration since we ran out of all of our other benzos on the ambulance. IM is great. It works relatively quickly, but there will definitely be patients where you're like, this guy needs to take a nap, and you're going to give him midazolam and nothing's going to happen. Usually the more agitated the patient is, the less likely the benzo will work when given IM, because they metabolize it too quickly. Okay, especially if you have a really hot patient, like the patient's temperature-wise is very hot, not sexy-wise, temperature-wise. If they're very hot, their body will metabolize the IM medication way before they are sedated. Questions? Cool. All right. So fentanyl. All of your pain medication, narcotics, all kind of work in the same exact way, where they bind to the mu opioid receptors in the brain, which prevents pain signal transmission. So your nerves can't trigger the mu receptor and tell the body that you're in pain. Most narcotics also have a relative contraindication for a head injury. because you can potentially put that patient into a coma and they will never wake back up. I had my own personal experience with that after I got chucked out of an ambulance. Stony Brook was trying to give me morphine for pain and I was refusing it because I was like, y'all gonna put me in a coma? And they were very confused as to why I was so sassy. The EMT uniform really should have given them a clue. So fentanyl is measured in micrograms as opposed to morphine, which is measured in milligrams. Fentanyl is 100 times more potent than morphine. So if you think about 100 micrograms is if you look at it on the scale with 1 milligram of morphine, there's like an inverse relationship, right? So if you could give a patient like 10 mics of fentanyl, they're going to have the same effect as like 1 milligram of morphine. Fentanyl doesn't cause the same amount of nausea as morphine does. Fentanyl is really kind of interesting. So they've started using it as in hospitals and like surgical clinics to sedate patients for like surgical procedures. And then they realized, they're like, oh, well, why is it so difficult to ventilate this patient? We had this exact job in Garden City. One of the outpatient like clinics had sedated a patient for, I think she was actually getting a nose job, and they gave her fentanyl to put her down so they could intubate her. And as the anesthesiologist is trying to ventilate her, he's like, I can't, I have no compliance, right? So if you push fentanyl too quickly, you can cause chest wall rigidity. Okay, so like all of the little muscles in between your ribs just stiffen up because the fentanyl just like kind of is too much for them. It's very common, but at the same time, a lot of people don't recognize it. So this goes back to making sure you get a really good patient history, especially if you're going to a 911 call at like one of these like, surgical clinics or something like that. Make sure you find out what they use to sedate the patient, because if they're having a hard time ventilating and they gave fentanyl, a little bit of Narcan can go a long way in fixing that. Nassau and Suffolk carry Toradol or Ketorolac. It is a super potent NSAID. It's really good for patients who have kidney stones. Super effective. It's good. That's definitely going to be a discretionary order though, because it's only currently in protocol for like extremity injuries. It's also good for patients, like younger patients who you maybe don't want to snow with narcotics. But patients who are older than 64, you need to really be careful with it because it does have a very high risk of kidney issues as well as GI bleeds. But overall, it's really good. It also works as an anti-fever medication. Oh, lidocaine, we talked about this already, right? So this is going to be used for patients who have a conscious IO, whereas it's slowing the sodium channels in the heart to work on the cardiac side. It's working in nerve sodium channels to prevent the transmission of pain. So basically how the sodium channels in the heart get slowed down, it's the same thing with the nerves, okay? So the nerves get slowed down by lidocaine so much that they can't transmit pain. Sort of similar to how they do it in the dentist, right? But you need to make sure that you are careful, because if it does go systemic, you can end up with cardiac issues. So that's why when you're pushing it into an IO, you need to make sure it's very slow to ensure that it's only going to be absorbed locally rather than systemically. Questions? Cool. Ondansetron, or Zofran, is a super, super popular antiemetic medication. We use it a lot. It's really good for patients who are making that really awful dry heaving noise, and you're like, no, we're done with that. It helps patients feel a lot better really fast. So it's a serotonin receptor in the brain. So the whole mechanism behind vomiting is that you are having pretty much a wash of serotonin over your brain, which causes vomiting, which is kind of cool and kind of weird at the same time. It's part of the reason that like patients who are really pregnant or a little bit pregnant have it, is because now their body is producing all this serotonin in response to the pregnancy. So they start having just like this wash of vomiting in the morning because of this influx in your neurotransmitters. So Zofran, what happens is it goes in there and it blocks the serotonin receptors and helps people feel less nauseous. It is safe for pregnant women, but you do need to make sure that if you're going to give Zofran, that you cardiac monitor patients, because it does have the potential to prolong the QT and create cardiac dysrhythmias. And that's the one and only antiemetic we have. Poisoning. They love amyl nitrate on the New York State test. I have never seen it on an ambulance, but it's one of those things that you should just kind of know of. It's used for cyanide poisoning, but you put it on like a cloth and like have them breathe it in. I don't know. I've never seen it, but they always ask about it. Yeah, it's like chloroform for your cyanide patients, which is like, you're just having a rough day if you've been poisoned with cyanide and you're now being like fake chloroformed. Yeah, he's like, here, sniff this. I don't want to sniff that. You'll be at the hospital in no time. Yeah, so it helps kind of, it binds with cyanide to prevent the cyanide from binding to your hemoglobin. But it's super flammable. That's exciting, because this is probably why we don't carry it on the ambulance, because it's probably lit one or two of them on fire. More effective for cyanide poisoning is hydroxycobalamin. It's a mouthful, but it's really fun to say. It's actually a B vitamin, which is kind of really cool, and it causes the patient, if you give it to the patient, it causes their urine to turn like bright red. But you need to make sure that you flush the IV really well. What happens is it goes in and it binds to the cyanide and then just makes it completely inert, and then it's excreted through the kidneys and into the urine, which is why it turns bright red. We use this in the smoke inhalation protocols in the city, or as a weapons of mass destruction protocol. But again, that needs a class action for you to use it. But you need to make sure that you also hydrate the patient really well, because now that you're giving them something that needs to be excreted, the body's going to diurese you, so they'll get really dehydrated if you don't hydrate them well. It's usually given in combination with sodium thiosulfate, which we'll talk about in a little bit. Narcan, if y'all don't know how Narcan works. Actually, what? Narcant? Narcandy, there you go. So Narcan comes in and it pretty much bumps narcotics off of the mu opioid receptors and then sits in the receptor itself, okay? So it's kind of competitive, but it has a much shorter half-life than most narcotics. So after about 20 minutes or so, if the patient still has a significant amount of opioids in their system, they will go back down into respiratory distress, AMS, because the Narcan will kind of break down and no longer be bound to the mu opioid receptor. You have to be very careful with Narcan, though. I know that sounds ridiculous because we're giving it out like Narcandy. But if you give it to a patient who is a chronic narcotics user, you can set them into flash pulmonary edema. Okay, I've seen it happen a number of times, where you give too much Narcan, and too much Narcan can be 0.5 milligram of Narcan, and the patient starts projectile vomiting. They start filling up, their lungs will start filling up with fluid, and they just go from like was unconscious to now having a severe panic attack because their lungs are full of fluid. So you have to be really careful and be gentle with the Narcan. I know we just like to slam it. I've seen some medics mix Narcan into an IV bag and give it a slow drip, so it's a more gentle wake up for some patients. That is not in protocol, but it is a consideration. IN administration is a little kinder, but if you do administer it IN, you might need to ventilate the patient to push the Narcan further into the mucous membranes. So just because you gave it and nothing's happening right away doesn't mean that it's not working. You might just need to use a BVM to push it a little further into the nasal passages. Hold on a moment. Pralidoxime, there we go, or 2-PAM, which is way easier to say. is used for organophosphate poisoning. It's in the duo-dose auto-injectors that you have in the city ambulances for weapons of mass destruction attacks. You need a class action suit by protocol in order to use the duo-dose. Basically, when an organophosphate comes in, it prevents cholinesterase from working. So you have this extremely high influx of acetylcholine at the neurojunction, the neuromuscular junction. So it causes a constant flow of stimulation into the muscles, which causes a lot of the sludge response, right? Because now you have diarrhea from the GI system being overstimulated and moving everything through way fast. You have, tears because now the tear ducts are being, stimulated to produce tears. So 2-PAM comes in and kind of reactivates the enzyme that breaks down acetylcholine and helps everything kind of return back to normal. It is only available in the auto-injector as opposed to atropine, which we also carry for cardiac. Sodium nitrite, again, is one of those things that we don't carry on the ambulance, but the state likes to ask questions about it. Again, it's used for cyanide poisoning. We don't see it very often because we use sodium thiosulfate instead because it's a little safer. So whereas sodium nitrite can cause significant hypotension if it's administered too rapidly, sodium thiosulfate does not have that same response. So basically the sodium and the thiosulfate sections, or the thiosulfate section, will bind to cyanide and it will release a sulfate. So rather than releasing a nitrite, it releases a sulfate. And then helps excrete the cyanide through the kidneys and keeps it out of the body, which cyanide is pretty cool in so much as you look completely okay, but you're dying from hypoxemia because your cyanide prevents the mitochondria from using oxygen. So your internal respiration is completely screwed up. So you will suffocate to death with having healthy lungs, which is just wild. We use these medications, the hydrocobalamin and the sodium thiosulfate, in smoke inhalation because cyanide is produced when plastics are burned. If you look at most of the construction these days, almost everything is plastic, right? You have PVC, you've got fiberglass, you've got all of these different plastic byproducts. So especially in house fires, you might have patients who have cyanide poisoning because of the plastics in the house that are burning. Older homes, like the ones like the 50s and earlier, have a lot less plastic and are actually a little safer to be caught in if they're on fire. Questions? Okie dokie. So we don't have RSI in Suffolk. Nassau is working on it, but that's, we're not even going to talk about that. Suffolk is the only one who has it. City doesn't have it. What you do need to understand is that a lot of these rapid sequence intubation medications work in the neuromuscular junction, right? So they'll bind to acetylcholine receptors and cause the continued depolarization. So it's sort of like you're inducing a short-term organophosphate issue, okay? So it's going to depolarize the muscles, so you create flaccid paralysis. But if it's a depolarizing muscle relaxant, it will create muscle fasciculations. There's like these weird and creepy looking twitches, as opposed to a non-depolarizing skeletal muscle relaxant, which doesn't cause the same fasciculations. The patient can experience transient hyperkalemia because when you are stimulating the muscle like that, it releases potassium into the bloodstream. If you are going to be using an RSI medication, you need to also know that when you administer it, you are completely taking over that patient, right? You are in charge of keeping them alive because they are not going to be breathing because you are turning all of their muscles off except for their heart. So you need to make sure that if you're going to, RSI someone, that you are prepared to tube and ventilate before you administer medication. So rocuronium is probably the most popular neuromuscular blocker that we see out and about on the street, especially in Suffolk, because it is a non-depolarizing medication and does not cause that really creepy muscle fasciculation. It is very common that you need to make sure that you sedate the patient as well. So just because you've paralyzed them doesn't mean that they're not still like awake to a certain extent. So this is where like a benzo would come in handy so that they don't remember that you've paralyzed them and then shoved a tube down their throat. Vecuronium is another one. It's also comes out and is popular, comes out to play. Again, no muscle fasciculations. You need to make sure you sedate the patient. And that's it. So that's all of our medications that we're really going to go over for today. Let me check the chat. Any questions? The assignment? Okay. Hold on, can you say that again? You're breaking up really weird. It's okay. Mm-hmm. Mm-hmm. Because it can cause increase in intraocular pressure, and cause blindness. It's a little fun side effect. Sure. The assignment is set up as a discussion board, so you can just put like a link or post. Probably a link will probably be the easiest for a Google Doc or whatever you decide to use to produce it. Just because it's designed so that it's like a study material for everybody, since it's all the medications that we're going to be seeing in the protocols. Okay. In the assignment area, yeah. I have a couple math questions if you guys want to do a quick math review, because I know that your your quiz today is like 100% math. So you would I'll do a quick review with you guys. Oh, damn it. Hold up. There we go. That's better. All right. So, you are asked to start a dopamine drip of 5 mics per kilo per minute on a patient who is 180 pounds. You have a 400 milligram vial of dopamine and a 250 milligram bag or milliliter bag of saline. What is your drip rate? So, what's the first thing that you guys want to do? All right, so you want to do micrograms. Okay, so let's see, 400. Somebody bitch, there we go, 400 milligrams. Okay. How am I going to convert that to micrograms? Times it by 1,000. Okay. Or, easy way, we could also go 1, 2, 3, and fill in your, because that's 1,000. That's times it by 1,000 also. Good. All right, so that is how many micrograms you have. Now what do you want to do? Okay, 180 into kilos. So how am I going to do that? Okay. So I'm going to move that decimal point over 1 for that to be 22. And move this decimal point over 1, 1,800. Move my decimal point up there. Okay. How many times does 22 go into 180? Danny, stop cheating with the calculator. Did you say 3? It's not right. 4. 4 is 88. 5 is 110. 6. Alright, it's 12. 6 times 2 is... Wait, yeah, 12. It's 13. 130. 2. Another 22. No? Anybody? 22. 6, 7, 8. Y'all gonna make me do math on my own, huh? All right, 22 goes into 20 0 times. 22 goes into 200. Nine times. Right? 18, 9, 18, 19, 198. Okay? So 20.9, because this is going to be a repeating decimal. Or 80.9, sorry. So there's your kilograms. Let's make that red. All right, so 81.81. Mm-hmm. All right, there's your kilograms. Okay. So what's the, you have, what formula are we using? Oh, shoot. Yep. Yep, what's your formula? There's 2, right? You have our volume over time times drip set. And we have our desired dose over dose on hand. Which one are we using? All right, good. So what's our desired dose? Five micrograms times kilo per minute, right? So do you need to do more with this? All right, so 81 times 5. All right, so this becomes what? No, is this our desired dose or a dose on hand? Okay, so if we go down to our formula, we have a desired dose, which is 405, over our dose on hand, which we don't have yet, times our drop set, which is going to be what, 60 or 10? I'm using a 60 drop set or a 10 drop set, guys? Yeah, 60, right? Because you're giving a very specific dose of medication. So you're going to use your 60 drop set. All right, so now what's our dose on hand? Okay, how are we going to convert that? Okay, so we have our micrograms. What's our concentration of dopamine? Right, you're going to put 400 milligrams, which is also 400,000 micrograms, into 250 milliliter bag, right? Cancel out your terminal zeros. Did we memorize the little dopamine trick I showed you guys last week? How many times does 25 go into 400? Oh, sorry, 25 go into 40. Yeah. So is this, what is this number now? What part of our formula is this number? Or the dose on hand? So if you do 405 times 60, over 1600. Cancel out your terminal zeros. So you have 243 divided by 16. 16 goes into 24. Oops. How many times does 16 go into 83? Four question mark? 5. Okay. We'll do it here for those of y'all who aren't seeing this. So it's 30. 5, 6, 7, 8. Decimal. Bring down 0. 16 into 30. Mm-hmm. $16 into 140. What was that? 8, yep. Oh, it's the eraser. No. Okay, and this decimal is going to keep going. So here's your answer. It's 15 drops a minute. Okay. This one's a little hard because the numbers don't work out pretty. But here we go. Here's another one. Go ahead. Exactly. That's why you have scrap paper and you learn how to do it. Also, your patient's never going to weigh 180 pounds. What's an easier, instead of 180 pounds right here, right? What works out to a nice, easy kilogram? That's too much. No, right? You have, right, all the different, if I go back, right, over here, look, 22, right? What's 22 times 8? It's 176, right? Is that relatively close to 180? So maybe your patient had, like, a good diet day, right? Because you're estimating patients' weights a lot of time. So if you did this whole thing again with, instead of 405, so right, we did over here, if we got our desired dose, that looks like a P, it's actually a T. So if our desired dose is 176, no, just kidding. 176 is 80 kilos. 80 times 5, right, is 400. Then you change this to 400 over 1600. Four times 60. 4 times 60. There. Anyone? Y'all need some coffee. 240. There you go. Divided by 16. Is that a... No, it should be closer. It should be relatively close to here. You should be getting 15. 240 divided by 16. There you go. 15 straight. Right? So that's how you're going to get around this on the fly in the ambulance. When you're doing it on the test, you're going to be going through all this other nonsense. When you're doing it on the truck, it's going to be 15 drops a second. Or a minute, just kidding. Well, see, but that's why you need to make sure that you memorize what your standard dopamine mixes are. Because you can spend a lot of time trying to figure out this portion right here, and you're wasting a lot of your time. It gets easier with practice, I promise. I will send it out to you guys. All right, another quick question. You're asked to administer 150 milligrams of amiodarone to a 154-pound patient. You have a 100 milliliter bag of a 0.9% normal saline and a macro drop set. What is your drip rate? All right, which formula are we using? Volume over time or dose on hand over, or dose desired dose over dose on hand? No. Amiodarone. According to your protocols, how do you administer amiodarone? Anybody? All right, let me specify the question. As per your protocols, how much time should you use to administer amiodarone? No, it's in your protocols. It's in, I think there's a whole protocol tablet actually. Yes, 10 minutes, beautiful. All right, so that's your time here, right? Let's put it in a different color. 10. All right, so you're doing 10 minutes. What's your volume? Is that a volume or a dose? Nope, you're putting 150 into 100 milliliters. This is where we're going to go over really quick, is you have to make sure you read the question carefully too. So if you're using your volume over time formula, I could tell you you've given this patient 300 milligrams of amiodarone in a 100 milliliter bag. It's not going to change your milliliters. So when you're looking for volume, it's always going to be milliliters. Okay? Most of the medications that we give it's a really simple volume over time formula, because you're usually using like 100 bag, or 250 bag, and your minutes are not going to be like a really difficult number. It's like 10 minutes, 20 minutes, something like that. All right, how many drops are in a macro drip set? There are 3 correct answers. 10 is one of them. 10, 15, what's the other one? 20, beautiful. Which one makes your life easier? 10. We like ones. All right, goodbye terminal zeros. So you have 10 times 10 equals, y'all. I lost most of you. Ah, goodness. All right. So it's going to be 100 drops a minute. Exactly. This one's an easy one. My spelling, not so good, but... All right. All right. We good? Not totally lost? All right. You order to start a dopamine drip, 15 mics per kilo per minute. Your patient weighs 220 pounds. Your partner has made you your dopamine mix of 800 milligrams in a 500 milliliter bag. What is your drip rate? What's our formula? Okay, milligrams to micrograms to get what? What is that you're calculating? Is it your desired dose or your dose on hand? Nope. There you go, dose on hand. So 800 milligrams is 800. Move over 3 decimal points. 1, 2, 3. Okay, in a 500 milliliter bag. Goodbye, terminal zeros. 5 goes into 8,000. How many times? I'm gonna divide real slow. For y'all. This should look familiar. 1,600. Okay, so if we go down here, my nifty little formula, my dose on hand is 1,600 micrograms per milliliter. That's a squiggle. Okay, what is our drop set? Because that's an easy one. $60. So now we need to find out our desired dose. What's the first thing we do? 220 pounds is how many kilograms? No. If you are giving dopamine, you're always using a 60 drop set. If you're giving norepinephrine, always a 60 drop set. Amiodarone or a volume over time formula can be whatever they tell you. There you go, 100 kilos. That was an easy one. All right, 100 kilos. We still have to figure out, you have to give how many? What's your dose that you're looking to give? Okay, so 100 times 15. So we plug this into our formula. Goodbye, terminal zeros. What's 15 times 60? You're asking a teller. There you go. Now 900 divided by 16. $56. We saying that with confidence or questioning? 56.25 with a calculator for the win. That wasn't too bad, right? Yeah. Yeah. And for the most part, you're not going to get a lot of the test questions they work them out so that you're going to have like a bizarre number. I just threw these together so that you had some review questions, so the math isn't perfect. All right, last one. I'll let you all get on with your day. You are asked to administer 4 mics per minute of norepinephrine to a 178-pound patient. I apparently had a small stroke while typing this. You mix 4 milligrams in a 250 milliliter bag. What is your drip rate? All right, so first things first, make sure you have an extra bag, absolutely. What's your essential information here? What's that? All right, so you're going to mix, right? So this is your, right? This is what you're mixing. Okay. Do you need to know how much this patient weighs? Good, right? That's a distractor. They are going to do that to you. So you need to make sure that when you're looking at this, you're reading carefully, right? If you don't have in here, right, is this your, right here, 4 mics per min, is this your dose on hand or your desired dose? Desired dose, right? This is your desired dose. There's no mention of kilograms in here, right? So you don't need to know how much your patient weighs. Okay? Quick and easy way for you to determine if this is this here is a distractor or not. Okay. So we're using our desired dose over dose on hand. Yes. It's just easier to write DD. All right, so if we fill in this in, we're filling in our formula here. My desired dose is 4 micrograms a minute. What's our drip set that we're going to use? Beautiful. So now what's our desired, our dose on hand? Blue. All right, let's go to red. How are we going to calculate our dose on hand? It's the same way you do with dopamine, except it's just different numbers. Say that again. All right, so it's going to go into 250 milliliters. Putting 4 milligrams in. Beautiful, right? Because you have to convert that 4 milligrams into mics. Okay. Goodbye, terminal zeros. Mm-hmm. $16 micrograms per milliliter. Okay. That becomes 16 micrograms per milliliter. So let's do this a little different way than we did last time, right? So instead of multiplying 4 times 60, let's simplify. There you go, 1 over 4, right? We're going to simplify that times 60 over 1 equals 60 divided by 4. A little more easy to manage, right? How many times does 4 go into 6? Once 4, 2, 15. So you have the concepts down. You need a little prompting, but you guys have it. Okay? And I'm going to send this to you again, but I'll write it really big for dopamine right here. So it's also on here as a review for because it's being recorded. Don't mind my horrible handwriting. So if you put 200 milligrams in 250 or 400 milligrams in 500, this is 800 mics per milliliter. If you put 400 in 250 or 800 in 500, this is 1600 mics per milliliter. This is also in the drug math PowerPoint that I posted from last week. It's at the end of it if you just want to go through the PowerPoint, but it'll be in this video as well. Okay? All right, any other questions? So it's really just, what you're really carefully looking for is, it's going to be a combination of what drug is being administered, and it's really the drug is kind of going to be a clue, okay? And it's also, if you look at, you are expected to administer, so a lot of times it's like amiodarone. Okay, you're gonna mix 150 milligrams into 100 milliliters, and you're going to use a 10-drop set to administer it. How much, or you're going to administer it over 10 minutes. Usually if they give you time, and if that time is not per minute, then you're using volume over time. If it comes up as like dopamine, norepinephrine, lidocaine, a lot of that is going to be your desired dose over dose on hand. Okay? All right. Any other questions, thoughts, or concerns, guys? Yeah. Okay. And the workbooks do have a lot of questions. If you guys have any questions where you're like, I am not sure, on the workbook, bring them next week and I'll go through them with you guys. I'll come up with some more math questions for you guys for next week that we can practice, because these are going to be things that you're going to see a lot, okay? All right.